صوتي واضح دكتور حسين؟ واضح كده ولا على صوتي
واضح،
اكتر؟
صوتك واضح كويس. بسم الله الرحمن الرحيم. طبعا احنا النهارده قبل ما نبدا المحاضره اللي انا متاكد انها تبقى محاضره قيمه من الدكتور علي شندي، لانه واحد من الناس المجتهدين جدا جدا يعني. اسمحوا لي جميعا، يعني انا مش هقول نقف دقيقه حداد، لكن احنا لازم نبدا بحداد استاذنا الدكتور هاني رفعت. ده طبعا استاذنا الدكتور هاني رفعت، الدكتور طارق طنطاوي كان عرفني عليه. وقلت للدكتور صبري جوهر ايام سنه، ده الكلام ده كان في ابريل 2008. قلت له لو سمحت انا عاوزين الراجل الموسوعه اللي عندكم. عرفت ان الدكتور هاني رفعت يعني من العلماء اللي بيقروا واللي مش حريص على حضور المؤتمرات ولا الشركات ولا الكلام ده، لكن عرفت انه يعني موسوعه علميه متحركه. فالدكتور صبري دعاه وهو جالنا هنا المنصوره في ابريل 2008، يعني من اكثر من 12 سنه. مودريت الكورس كان على الالكترونات والازيد بيز ديستربنس. سيشن كان فيها 12 كيس وفيها تيتش مسجز احنا كنا بنقولها، لكن تعليقات الدكتور هاني كانت تعليقات بتنم عن عمق معرفه. وبعد كده طبعا الواحد شفته في اكثر من موقف، وكان ظهوره في المؤتمرات قليل جدا، لكن هو لمس فعلا قلوبنا كلها بالسلوك الطيب والاخلاق الحميده. وطبعا الدكتور هاني رفعت، ودي من الصور النادره اللي موجود هنا طبعا مع الدكتور عمرو سرحان، كان عميد الكليه في التوقيت ده، الدكتور حسن ابو العين مدير مركز الكلى، وكان معنا الدكتور هاني رفعت كعالم كبير جدا اسرى هذا اليوم. فطبعا له منا كل يعني الدعاء بالرحمات، وان ربنا سبحانه وتعالى يسكنه فسيح جناته، لانه هو فعلا يعني انسان قدم كثير، واعتقد في الدنيا ما اخذش كتير. فانا اعتقد ان رصيده ان شاء الله هيبقى في الاخره كبير جدا جدا، واحنا كتلامذه له بندعي له بالمغفره والرحمه، وبنعزي مش اهله، بنعزي نفسنا، لان احنا يعني احنا من اهله. الدكتور هاني رفعت استاذ عزيز، استاذ امراض البطنه والكلى في جامعه عين شمس. ترك طبعا الم في النفوس، لكن عزائنا ان شاء الله انه هيلاقي عمله الصالح وما تركه من علم شفيع له ان شاء الله يوم الدين. انا اسف ان انا بدات بدايه حزينه، لكن انا طبعا تقدر يا دكتور علي دلوقتي تعمل شير بعد اذنك السلايد بتاعتك. دكتور علي
مع حضرتك دكتور حسين.
حضرتك افتح الباوربوينت واعمل لها مينيمايزيشن كويس زي الفل.
تمام.
انا احب قبل ما حضرتك تبدا ان طبعا اقدم الدكتور علي شندي تقديم يعني انا متوقع منه محاضره مهمه جدا، لان اللوبس نفرايتس من الموضوعات الخطيره جدا في النفرولوجي، في كلينيكال نفرولوجي وفي جلوم نفرايتس بشكل عام. وانا جالي ريكوست كتيره عاوزين نسمع اللوبس نفرايتس، وانا كنت فعلا اجهزها، لانه طبعا في ابديت كتير موجود في اللوبس نفرايتس، ومن الموضوعات كل يوم بنشوف بنمر على حالات كلينيكال نفرولوجي بنلاقي اللوبس نفرايتس شيء مهم جدا وازاي نتعامل معاه. الدكتور علي شندي طبعا استاذ مساعد في جامعه الزقازيق في وحده الكلى، هو ISN ويو كي فيلو. والدكتور علي شندي من خلال المؤتمرات الجامعه المصريه والابستراكت ميتنج الابحاث اللي بيقدمها هو شخص مختلف، وان شاء الله يبقى استاذ عظيم جدا جدا جدا. وانا مش عاوز اعطل المحاضره اكتر من كده، لكن انا متوقع ان المحاضره هتبقى قيمه، وبنتهز الفرصه. انا شفت الدكتوره مي معانا اهيت، ارحب بالدكتوره مي طبعا استاذتنا كلنا. وهي والدكتوره مي ما اعتقدش ان حضرتك حضرت الجزء الاول، احنا عملنا عزاء يعني من شعبه التعليم الطبي المستمر للدكتور هاني رفعت استاذ
أيوة.
امراض. فيعني لو
طبعا
حضرتك عاوزه
طبعا
لو حضرتك عاوز تقولي كلمه في تعزيه الدكتور هاني، بنعزي انفسنا يعني، اتفضلي.
احنا فعلا زي ما انت قلت دكتور حسين، احنا بنعزي انفسنا فعلا. دكتور هاني الحقيقه كان قامه وخلق، ومش عارف الواحد مش عارف يقول ايه بصراحه. ربنا يرحمه، وان شاء الله كل الخير اللي عمله هيلاقيه مستنيه باذن الله، ويعيننا بقى على الفراق وعلى الفقد الشديد اللي حصل لنا، يعني الحمد لله.
ربنا يبارك في حضرتك. انا قلت قبل ما حضرتك تجون اس ان هو ترك السيره الطيبه والعلم النافع ان شاء الله اللي هيبقوا شافعين له باذن الله يوم الحساب اللي هو اليوم الحق.
اللهم امين.
مش عايزين نزود جرعه الحزن عن كده، وهي الدنيا كده لابد، يعني هي الحقيقه الثابته هي الموت. والنهارده الدكتور ان شاء الله علي شندي هيحيينا بقى في از هاو تو مانج لوبس نفرايتس. دكتور علي اتفضل.
موضوع مهم
جدا. اتفضل دكتور علي.
بشكر حضرتك دكتور حسين على التقدمه اللي فيها اكتر ما استحق. يعني برحب باساتذتي جميعا وزملائي اللي موجودين معانا. ان شاء الله ربنا يزيح الغمه قريب ويعدي الفتره دي على خير ان شاء الله. انا هبدا الموضوع النهارده الدسكشن مع حضراتكم بكم كويستشن كده نفتح شهيتنا بيهم. هل حضراتكم توافقوني في الجمل الاتيه ولا لا؟ اولا kidney biopsy in the context of lupus nephritis indicated mainly لما يكون تشخيص lupus nephritis صعب كلينيكالي او cannot be made clinically. دي اول جمله. ثاني جمله induction therapy ب MMF yield a higher remission rate than cyclo-based regimen in Caucasian patients with LN او lupus nephritis.
يعني الجمله انت حضرتك بتفتحهم للاسئله ولا بتفتح؟
لا just for thinking واحنا خلال الموضوع هنستعرض النقط دي ونجاوب عليها.
تمام جميل اتفضل.
Maintenance therapy with azathioprine is more effective than MMF-based therapy in maintaining relapse-free remission in patients with lupus nephritis. Class 5 lupus nephritis, the membranous should be treated with immunosuppression regardless kidney function and the level of proteinuria. وأخيراً, hydroxychloroquine is only recommended during the initial phase of SLE therapy. دي الأجندة طويلة شوية بس إن شاء الله مش هتبقى يعني الموضوع مش هيبقى طويل قوي كده. كلمة لوبس يعني ذئب باللاتيني زي ما حضراتكم عارفين، ويمكن التسمية تقريبا جت من القرن ال 13. هل بسبب ان المالر راش بيخلي شكل العيان عامل زي الولف، او بسبب ان الديزيز اجريسيف نيتشر زي الولف اللي احنا شايفينه؟
اكسكيوز مي دكتور علي.
اتفضل يا فندم.
دكتور علي, I have here in the chat a note that there are some English speaking attendees and guests from respectable guests from different countries speaking only English. So would you please restrict the presentation to English?
Yes, that's fine.
Okay, as you can.
That's fine. Starting as we all know that lupus in Latin means wolf, and the name of the disease come perhaps from the 13th century. It may be due to that the malarash that present in patient with SLE may give him a picture like this wolf, or because the disease has an aggressive nature like a wolf. But let's agree that the disease has an aggressive, we deal with a disease with such potentially aggressive nature like this wolf. And let's start our discussion with this case story. It's a usual case that we meet in our clinics. 32-year-old lady, she is a female in childbearing period, presented simply with dyspnea, low lymphedema, and severe hypertension recently developing. And her blood pressure on admission or on examination was 170/120. I'll give the case story in summary, no details about, except the positive points. On urine dipstick examination, the albumin was +3 and the red cells was 8 to 10 per high power field. There was microscopic hematuria and albuminuria in this patient. So we had 24-hour urine protein analysis, and it was 4.7 gram per day, and creatinine was elevated at 1.5 milligram per deciliter. For sure, we had the assessment of the inflammatory markers, and the ESR was 82 millimeter in the first hour, and the O2 antibodies turned out to be positive for ANA, positive anti-double-stranded DNA by ELISA 207 titer, and the C3 and C4 were consumed. Clinically speaking, we are in face of a case with SLE and clinical evidence of lupus nephritis, and there are some clinical questions that we should ask ourselves, and we will meet in practice. First, do we need a kidney biopsy in this context? The second question, what initial management should be? I'll answer the second question. We should start by intensive blood pressure control, preferably using RASP-looking agent. And then the patient recalled the history of having DVT during pregnancy 4 years earlier, and 3 times abortion. Perhaps the abortions didn't attract the obstetrician attention because they were not consecutive. she had 3 children, 3 full-term successful pregnancies. Had a kidney biopsy, and it showed lupus nephritis class 3 and 5, mixed lupus nephritis class 3 and 5, active early chronic. The biopsy report didn't provide the activity and chronicity indices, just active and early chronic, and we will discuss this point later on. The next question now that we ask ourselves, what other antibodies to be assessed? And I think we should think about having secondary antiphospholipid antibody syndrome. And it is recommended to screen for antiphospholipid antibodies, the lupus anticoagulant, anticardiolipin, and inhibitor-2 glycoprotein in every lupus patient, particularly when having a history like that, suggesting secondary antiphospholipid. Which immunosuppressive regimen to recommend, and whether this regimen will be for life, we will discuss these points later on during the talk. And the last question, what other medications to prescribe? For sure, hydroxychloroquine and the lifelong anticoagulation if we prove the antiphospholipid antibody syndrome. Let's start with an introduction about epidemiology. And when we look at this world map, we can see that the prevalence, this map is colored according to the prevalence of SLE in different countries. And those countries with no reliable epidemiologic data are not colored, they are left in gray. The prevalence of SLE range 25 as 25, perhaps in Northern Ireland, Finland, and Denmark, to as high as around 150 per 100,000 population in South America. In the UK, the yearly incidence per 100,000 population is around 5 patients per year. And the prevalence increased over years from 1999, 65 patients, to 97 or around 100 per 100,000 population in 2012. And in this area, in countries with multi-ethnic population, those patients belonging to these areas, South American, of Hispanic ethnicity, of African ethnicity, South Asian, had higher frequency of lupus nephritis, early onset lupus nephritis, more aggressive nature of SLE, those areas of the world that doesn't have reliable epidemiology data. Patients from these areas tend to have higher frequency of lupus nephritis, early lupus nephritis, and worse outcome consecutively regarding death and end-stage renal disease. And we will need this data regarding these ethnic groups while we speak about the treatment options. And we know SLE is predominantly disease of childbearing females, childbearing women. About half of the patients develop nephritis. And the risk factors to develop nephritis will be young age at presentation, male sex, and again, non-European ancestry or non-European ethnicity. Usually, nephritis develop early in the disease. If it's not the presenting feature of the disease of SLE, it develop usually within the first 6 to 36 months of presentation, and it confers higher risk for mortality and for morbidity during the course of SLE. Then when we face a patient, how to make a diagnosis, when to suspect lupus nephritis. Clinically, there are subtle clinical manifestations. The clinical manifestations are few, but should warn us towards the possibility of having lupus nephritis. Just low lymphedema, periorbital puffiness, and increased blood pressure may point out for the urine. Perhaps the patient may complain from this. And so to diagnose lupus nephritis, most commonly it occurs with screening by investigations, just simply urine analysis and kidney function assessment. When to opt to screening a patient for lupus nephritis, whenever we suspect SLE, whenever a patient with SLE at initial diagnosis presents, and whenever we suspect a lupus flare during the course of SLE. And regularly following up a patient, at least every year, we should screen for lupus nephritis. How we should screen? We just do urine analysis and screening urine ratio, urine protein creatinine ratio, and if it turned out to have proteinuria, we should do 24-hour urine collection, and we should rely on 24-hour when we are making important decisions in patient management and depend on PCR just for screening or for follow-up of the patient during management. Kidney function assessment with creatinine and eGFR, and that's all. The symptoms that can alarm us towards the occurrence of lupus nephritis occur, which are shortness of breath and leg edema, occur at a frequency of just above 30% in the course of systemic lupus, and they are non-specific. So we should screen the patient. In a patient with lupus nephritis, there are the clinical criteria that we encounter, and proteinuria occur in 100% of patients with lupus nephritis. And this goes up, the proteinuria level goes up to reach a nephrotic level, which is 3 to 3.5 grams a day in 50% of the patients. In a third of the patients, they have hypertension. Microscopic hematuria occur in about 3/4, about 80%, and in less than 5%, there may be obvious macroscopic hematuria. This is unusual finding. Renal insufficiency occur in about 2/3 of the patient, with rapidly progressive or rapid declining kidney function occurring just in 15% of the patient. So simply, proteinuria occur in 100% of the patient, 50% nephrotic range, and in a third hypertension, 2/3 with renal insufficiency. Which antibodies are relevant or important in diagnosing and following up patients with systemic lupus erythematosus or SLE? First, I'll highlight the important antibodies. First, ENA is the most sensitive antibody, holding sensitivity of up to 98%. Second, the most specific antibodies are anti-double-stranded DNA anti-Smith antibodies, having specificity of 95% in anti-double-stranded DNA and 99% in anti-Smith antibodies. And these two antibodies correlate with the occurrence of lupus nephritis. And when they are positive, they point towards the possibility or high likelihood of having lupus nephritis in the patient. Anti-double-stranded antibody are characterized by having a titer that can be correlated with the activity and can be used to follow up response, immunologic response to therapy. Lastly, the antiphospholipid antibodies, if it's right to call them like that, who are the lupus anticoagulant test, anticardiolipine IgG and IgM antibodies, and the anti-beta-2 glycoprotein antibody IgG-IgM, which should be, as recommended in the most recent EULAR, European League Against Rheumatism, guidelines in 2019, and the category draft 2020 for glomerular diseases, to be screened in every patient. Over the years, diagnostic criteria to diagnose SLE has developed since the revised ACR, American College of Rheumatology criteria, in 1982, which was revised in 1997. We all are aware of these criteria, which are 11, and we need 4 to diagnose SLE. However, these criteria suffered poor sensitivity. And so in 2012, the SLEC Systemic Lupus International Collaborating Clinics classification criteria were developed, which were complex, and recently, in September 2019, were replaced by the EULAR ACR classification criteria, European League and the American College of Rheumatology criteria for SLE. And I'll rapidly go through the most recent classification criteria, which has 2 major advances. The first is that the ENA as an antibody, the most sensitive antibody to diagnose SLE, in the past criteria were put at the same level of importance with other antibodies. It's not the case here. The antinuclear antibody were taken out from the classification criteria and put as a classifying criteria on its own, as an entry criterion. If NA at a titer of more than or equal 1/80 by immunofluorescence or other equivalent testing method, if it is positive, then we will go to other criteria. If it is negative, we will not classify the patient as SLE. And this has in science. This point improved the specificity of the criteria. However, the negative downside of the criteria is that the subclass or the category of SLE, of ENA negative SLE, will be missed from diagnosis, and this point will depend on the clinician clinical sense and individual patient suspicion and other diagnosing utilities, and this open way for further research to find other markers. These are the other criteria. When we find this ANA positive, we will go through other criteria, which now are put in 10 domains, the clinical and immunologic domains. And under each domain, the criteria are given score according to their weight in the individual patients. And we count under each domain the point with the highest score. For example, if we have 2 immunologic parameters, leukopenia and thrombocytopenia, we will give the patient a score of 4, not 7. First fever, for the first time, fever enters as a diagnostic criterion for SLE, hematologic, neuropsychiatric, mucocutaneous. I'll not read them in details, serosal, musculoskeletal, and renal. The immunologic criteria, antiphospholipid antibodies, and complement proteins and SLE-specific antibodies. Back to the renal criteria, if you look deep here, the renal biopsy class 2 and 5 have the highest score among all the other parameters, 8, and 10 for the renal biopsy class 3 to 5 lupus nephritis. And to be honest, it's sufficient to have a patient with ANA positive and renal biopsy class 3 or 4 to diagnose SLE. We need just 10 overall score plus the entry criterion to classify a patient as having SLE. So in our patient, ANA was positive. She had proteinuria more than 0.5 gram. She had anti-double-stranded positive low C3, C4. These are the available points towards a diagnosis of SLE, score 14. So she is diagnosed with SLE with high clinical index of suspicion for, or clinical diagnosis of lupus nephritis. Why we adopt these criteria? Because they improve the sensitivity and specificity in comparison with the previous criteria. Low sensitivity in the ACR and the low specificity in the SLEC criteria. But we should put in mind again here that ANA positive patients in the cohorts used to develop these criteria represented 99.6 and 99.3%. So 0.7, 0.4 to 0.7% of the patients will be ANA negative. The question now is, do we need a kidney biopsy in this regard? Literally speaking, the gold standard for diagnosis and classification of lupus nephritis is the kidney biopsy, and we will opt for having kidney biopsy on almost all lupus patients who have evidence of renal involvement. I mean, having proteinuria more than 0.5 gram a day, having active urinary sediment and persistent hematuria in the form of persistent hematuria and or cellular CAS, especially with the presence of proteinuria, even if it is below the 100 gram threshold, having rising creatinine with no other explanation, then we will have a kidney biopsy in these conditions. Literally in every patient with clinical suspicion of lupus nephritis. However, we should put in mind that having only asymptomatic microscopic hematuria without proteinuria or proteinuria less than 0.5 gram in the absence of active sediment does not warrant towards having a kidney biopsy. We will not need a kidney biopsy in these situations. And the rationale for having kidney biopsy is first to establish a diagnosis of lupus nephritis, and more importantly, to understand the histologic subtype that will have an impact on the choosing the therapeutic approach to the patient, will imply on prognosis, and knowing the extent of acute and chronic kidney injury, that will also have therapeutic implications. We did the first diagnostic kidney biopsy, and then later on during the course of management, when do we need a repeat kidney biopsy? In this nice diagram, first we had a diagnostic biopsy, and then we give the patient our therapy, induction followed by maintenance, and the therapy outcome will be in the form of one of three options. First, if the patient did not respond, the worst scenario, if the patient did not respond to the therapy and had a treatment-resistant disease, whether in the form of persistent nephrotic proteinuria or worsening kidney function, we will opt to have a repeat kidney biopsy. Rebiopsy will either show us that the patient have ongoing active disease or worsening histologic pattern, increasing activity, so we will intensify therapy, or show that the patient have increasing chronicity scarring, and in this case, no further treatment will be added. The other therapeutic response, response to therapy will be partial renal response, and if the patient, after 1 year of starting the maintenance therapy did not develop complete renal response, a question mark will arise in the managing physician's head about whether the patient intensifying immunosuppression will convert the patient from partial response to a complete response, whether the patient needs therapy intensification or not, and in this situation, perhaps we may know histologic activity versus chronicity, and we will need a kidney biopsy in this situation. And lastly, the third response will be a complete response. And for sure, if in the context of complete response, we will only ought to have a kidney biopsy if the patient developed a flare and the first biopsy showed evidence of class 2 to 5, or if there is another suspicion or a possibility for an alternative diagnosis to have a proliferative pattern. The last indication for having renal biopsy if the patient went smoothly through the course of therapy and developed a complete remission for more than 1.5 years, and we are thinking after about 3 years of therapy, we are thinking about completely stopping the therapy, and perhaps we may need to have a rebiopsy to verify histologic remission and absence of any activity before taking the decision to stop therapy. We had a biopsy and we are looking at the biopsy now. The benefit will be about the histologic findings will be the class, the lupus class, and the indices activity and chronicity indices. Recently, this month, about a day or two ago, the KDIGO draft, the draft for the 2020 KDIGO guidelines for management of glomerular disorders were released as a draft for public review. And I invite you to go to the KDIGO website and start reviewing these guidelines, and all the reviewers will be acknowledged in the final draft. Till the draft of the KDIGO guidelines, we still rely on this 2003 abbreviated ISN Renal Pathology Society classification of lupus nephritis. We are all aware of the 6 classes. And in the most recent guidelines, it is recommended as well to provide in every biopsy report the active and to look carefully for the items of active and chronic histopathologic features affecting different elements of the kidney. I not go in the pathologic details, but rather go through the correlation with clinical findings, how to anticipate certain pathologic class, lupus nephritis class. In class 1 with minimal mesangial lupus nephritis, where there are some immune complexes deposited in the mesangium, I will not expect that there will be manifestations or findings related to the kidney, so this class will be rarely diagnosed or biopsied altogether. In class 2 lupus nephritis, where there is some mesangial proliferation, we will not expect that there will be florid findings. So the findings will be limited to just low-grade proteinuria and some hematuria. Renal insufficiency and nephrotic syndrome are not expected unless there is element of podocytopathy, lupus podocytopathy, that will be diagnosed only with electron microscopy. Class 3 and class 4, the collectively called the proliferative patterns of lupus nephritis share the same clinical manifestations or the same clinical criteria, having proteinuria and hematuria in most patients, and commonly to find renal insufficiency and even nephrotic syndrome. These are not unusual. Class 5, the membranous lupus nephritis, characteristically will have, like the membranous, the usual membranous nephropathy, characteristically will have proteinuria, perhaps having some hematuria, and the proteinuria often nephrotic range and having higher levels of 24-hour urine protein. Usually kidney function is preserved. Lastly, when over 90% of the glomeruli are sclerotic and class 6 lupus, advanced sclerotic lupus nephritis diagnosed, renal insufficiency will take the upper hand, will be number 1 in the list, followed by some proteinuria and hematuria that are often present. Just to give a highlight on the importance of activity and the chronicity indices that disappeared in the pathology reports for a while and came back after recommendations of this meeting that was reported in 2018 in Kidney International, enforcing that the 6-parameter 24 from 0 to 24 activity score and the 4-parameter from 0 to 12 chronicity score should be reported and should be looked for in every biopsy report. And this was the statement we advocate the usage of these indices in all classes, as they provide more information than the shorthand AC and just AC parameters. After having a biopsy and knowing the class and knowing the chronicity and activity indices of the patient, we should think now about management of lupus nephritis and whether the management strategy, the one-size management strategy will fit all. For sure, no. Let's look at this diagram. When we suspect the lupus nephritis and we had a kidney biopsy, we performed a kidney biopsy, our findings will be the proliferative patterns. First, the non-proliferative lupus nephritis, class 2, and the class 5, the subnephrotic class 5 or class 5 with subnephrotic proteinuria that will elicit some debate, perhaps, will be managed with immunosuppression targeted against the extrarenal disease. Whereas, and as well, the same principle will apply to chronic lesions 6 or 3 and 4C, chronic 3 and 4, immunosuppression will be targeted by the extrarenal disease, targeted to the extrarenal disease. In proliferative lupus nephritis patterns in class 3 and 4, active or active chronic, and in mixed class 3 or 4 plus 5 plus the membranous, or in membranous but having nephrotic range of proteinuria, we will guide immunosuppression towards treating lupus nephritis. In non-lupus nephritis, in the non-classic lupus nephritis kidney disease, lupus podocytopathy, that can be considered as a variant or form of lupus nephritis, TMA, interstitial nephritis, globulinemia, acute tubular necrosis. These findings may be evident on biopsy and will be managed on their own. For sure, the umbrella that covers all these categories, all these classes and levels of chronicity or activity, hydroxychloroquine and kidney protective measures, and other measures to tackle or to manage, avoid complications of SLE, and or its therapy will be given to the patient. Strict blood pressure control, preferably with renin-angiotensin aldosterone or RAS blocking agent. And perhaps in the future, SGLT2, if it is approved, perhaps. To summarize, class 2 unless nephrotic and class 6 with class 5 subnephrotic immunosuppression for extrarenal disease, immunosuppression for lupus nephritis in proliferative, and class 5 the nephrotic form of it. Let's go deep to discuss immunosuppression, immunosuppressive strategy for proliferative forms of lupus nephritis. Again, 3 or 4 plus 5 the mixed patterns. Unfortunately, first we have immunosuppression. Immunosuppression will be in 2 stages. The first is the induction or initial phase. And over the 2 stages, unfortunately, we have our immunosuppression is non-targeted. We don't have till now targeted immunosuppressive regimen. The duration of the initial phase, the induction phase, will be 3 to 6 months. And this phase includes 2 major pillars, 2 major components, the high-dose corticosteroids plus one of the following agents. First, cyclophosphamide, second, MMF, and the recently added in the KDIGO draft 2020 multi-target therapy. And now to the dosing regimens of each of these drugs. Cyclophosphamide, there are 3 dosing regimens. The old one, NIH, IV cyclophosphamide, high dose and prolonged course of IV cyclophosphamide, half to 1 gram per square meter. It's not absolutely half to 1 gram, it's half to 1 gram per square meter. And let me remind you, please, that the average adult has an area of 1.8 to 1.9. So the dose in some cases may exceed a gram of cyclophosphamide a month. And the total dose will be, after 6 months of therapy, 9 to 12 grams. The second regimen is the Eurolupus regimen, which is the low dose, smaller dose, and shorter duration regimen, 500 milligrams every 2 weeks for 3 months, 6 doses, and total exposure will be 3 grams. It's almost a third to fourth cyclophosphamide exposure when compared to the NIH, National Institute of Health regimen. And lastly, the oral cyclophosphamide, which entails higher toxicity, a higher side effect profile than the previous two regimens. The dose will be 1 to 1.5 milligram per kilogram per day over 3 to 6 months. And I doubt that any of us uses this regimen. MMF will be used in a dose of 2 to 3 grams a day for 6 months. According to the patient tolerance for the development of GI complications, diarrhea, and the leukopenia, blood dyscrasia development. Lastly, the multi-target therapy, which includes reduced dose MMF, which try to solve the issue of tolerability with an added calcineurin inhibitor, whether tacrolimus in the original Chinese studies or recently voclosporin, if this regimen is approved. And we will discuss this regimen in details now. Regimen for a particular patient. The choice of therapy will depend upon these 6 factors. First, drug availability and financial aspects. Price. MMF is much expensive than the cyclophosphamide. The likelihood of adherence. If we have a patient who will not adhere or who we suspect is adherence to an oral therapy, then we will opt to give intravenous therapy. Age, for sure, cyclophosphamide and the fertility issue in child period. And previous prior immunosuppressive exposure, the malignancy risk with multiple cyclophosphamide doses. We are not only speaking about the naive patient, we are speaking about induction therapy for prior exposure to immunosuppressive therapy. This tempo and severity, and in this particular issue, the high dose or standard dose cyclophosphamide may have a role, may still retain some role in therapy. In severe disease, in a bit of disease, standard dose cyclo may be considered. Race and ethnicity, Hispanics, African, and Chinese populations differ from the European population because the Euro-Lupus regimen, the low-dose cyclophosphamide, was first tested in the Caucasians essentially, and it had it showed equivalent efficacy to the NIH regimen in Caucasians and less side effects, so it's preferred in Caucasians. And recently, some new studies, or there have been some emerging data that this Euro-Lupus may be effective in other ancestries as well. Preferred in Black and Hispanics. The cyclo regimen and the best cyclo regimen to prefer in non-Europeans still have a question mark beside. We will go through the evidence behind each of these assumptions now. Looking at the recommendations of the KDIGO draft, the most recent KDIGO guidelines, the recommendation for induction therapy has differed a bit from the prior guidelines. That it didn't consider the NIH or high-dose cyclophosphamide. It just mentioned that the patient should be treated initially with corticosteroid plus low-dose IV cyclophosphamide or mycophenolic acid analogs. And the practice recommendations were as follows. When considering a mycophenolic acid analog-based regimen, it should be considered as the initial therapy for patients at high risk of infertility, moderate to high prior cyclophosphamide exposure, and patients of Asian, Hispanic, or African ancestry. In these categories of patients, we should opt for this. We should give the MMF-based regimen a priority. And when should we think about the IV cyclophosphamide? When there is an issue about adherence to therapy or compliance, when there is difficulty adhering to an oral regimen, when they expect compliance in the patient. The last regimen, which is the triple immunosuppressive regimen, including calcineurin inhibitor and reduced dose mycophenolic acid analog and corticosteroid, reserved for patients who cannot tolerate standard dose MMF and unfit or will not use cyclophosphamide. When the other previous two regimens fail or unacceptable for the patient, we should try the triple immunosuppressive regimen. also fail, other therapies such as azathioprine or leflunomide can be tried. During initial therapy of the patient, we should monitor the patient in regular visits every 2 to 4 weeks during the first 3 months. And then when the patient is stable, we can further space the visits till being every 2 to 3 months. And in every visit, we should assess for creatinine, and we should do urine analysis, urine protein creatinine ratio, C3 and C4, and antidouble stranded with activity, and point out to the serologic or immunologic activity of the patient, CBC, liver functions, and finally, perhaps we may assess ESR, the inflammatory marker. Now, which regimen we should give the glucocorticoid therapy according to? If the patient do have severe active disease, and we mean by the severe active disease, if the patient have rapidly progressive glomerulonephritis, rapidly deteriorating function, severe extrarenal manifestations, we are thinking about giving high doses of pulse methylprednisolone, 250 to 1,000 milligram over 30 minutes for 3 days. Some people may delay giving cyclophosphamide till ending the 3-day course of methylprednisolone, and this is not the standard practice. We should give the cyclophosphamide at the same time, because the response of cyclophosphamide, amongst other immunosuppressives, may not be seen for 10 to 14 days, may be delayed. So we don't need further 3-day delay. If the patient has manifestations of the patient doesn't have severe active disease, that's if we find that the patient has stable kidney function, we can start with the conventional doses of oral glucocorticoids, 60 milligram a day. Going down from 60 milligram a day in stable patient, we should taper steroid till reaching a dose of 5 to 7.5 by the end of the induction phase, or the initial period, the 6th month initial period. And the tapering strategy differ according to the institute, differ from clinicians and according to the patient response. Let's take an example in the ALMS trial. In the Aspiriva lupus management study trial, the investigators opted to withdraw with prednisolone, oral prednisolone, every 2 weeks initially by 10 milligram till 40 milligram a day over a month. And then by 5 milligram down to 10 milligram a day over another 2 months. And if the patient is stable, they continue further tapering for 4 weeks. Myself in my practice, I tend to start to withdraw by 2.5 milligram a day below 20 milligram a day dose of prednisolone. Other regimens of prednisolone withdrawal are available. In the most recent recommendations, this is an example of corticosteroid regimen in 2 dosing schemes, the standard and the reduced. Even if you look at the timetable here, over 12-week period, 3 months, just over 3 months, they withdrew prednisolone to a dose of 5 to 7.5 milligram. They suggest withdrawal or tapering to this level. And in the reduced dose scheme, as an example, the suggested withdrawal will be to even below 5 milligram a day over the 3-month period. And again, this is just an example of how we can withdraw steroid therapy. Now let's rapidly screen choosing or for preferring one immunosuppressive over the other. First, comparing or investigating cyclophosphamide versus MMF. The landmark Aspiriva trial, which was published in 2009, compared mycophenolate mofetil versus the standard dose or high dose IV cyclophosphamide, and found that overall, in the overall study population, there was no significant difference. Both gave similar response rates. This is the condition or the situation in Asians, in Caucasians. However, in the category called others, which are expected to include Hispanics and African Americans, the p-value here is significant in favor of mycophenolate mofetil. Perhaps this is the start where mycophenolate mofetil started to gain popularity or gain attention to be the agent of choice in patients of Hispanic and African American or African ancestries. The best evidence is a systematic review or a meta-analysis. And this, 2 years later, this meta-analysis was published in the Journal of Rheumatology. And again, there was no difference between MMF and cyclophosphamide in terms of patient response among different studies. They both can be used alike or can be used with the expected similar response rates. Looking for an Egyptian experience, the study was done and was published in 2010. And here, if you look at the p-values, this is the summary of all primary and secondary endpoints of the studies, which was a randomized controlled trial, randomizing patients to having either mycophenolate or high-dose IV cyclophosphamide for induction therapy in proliferative Egyptian patients with lupus nephritis. Looking at the p-values where all were non-significant or insignificant in all primary and secondary. Both treatment regimens give similar response rates. More recently, in Kidney International in 2016, the study was published and was done in India. So patients of Asian ancestry, South Asian patients were included, comparing for the first time between the low-dose intravenous cyclophosphamide and oral mycophenolate mofetil. And if you look at these graphs, the cyclophosphamide and MF arms did show similar response rates. So in 8 patients, the conclusion was that low-dose IV cyclophosphamide is as effective as oral MMF. Oral MMF, if you remember, had a preference over standard dose cyclophosphamide, and when perhaps African, Asian, when we tested for the low dose, sorry, the preference was in Hispanics and Africans only. And in Asians, they were alike. And looking at the low dose IV cyclophosphamide was similar to MMF with fewer GI side effects and good induction option for patients of Indian ancestry or Indian population. If we consider price and lower GI effect, 5 IV cyclophosphamide would be a considerable option. Comparing or considering the evidence, comparing low dose versus high dose cyclophosphamide now. The first trial comparing the efficacy and safety of low dose and versus high dose cyclophosphamide was the Lupus nephritis trial, the ELNT trial, which was published in 2002, sorry. And they were looking at the graph, there was no significant difference in both arms. And this trial included mainly Caucasian patients, European patients, or patients of European ancestry. And even after 10 years of follow-up, still the two groups didn't show significant difference in terms of the end-stage renal disease free percentage or the percentage free from sustained doubling of serum creatinine. The p-values in 2 were not significant. So again, low-dose cyclophosphamide with the low side effect profile was or gave short and long-term outcomes similar to the high-dose cyclophosphamide approach. But essentially for European patients. Looking at an Egyptian experience, this study was done in Mansoura Urology and Nephrology Center and was published in 2009, comparing two therapeutic approaches based on cyclophosphamide low dose versus high dose. Inclusion in summary, a remission-inducing regimen of low dose gives similar outcome to a high-dose regimen in Egyptian patients with proliferative lupus nephritis without serious complications. So in Egyptian patients, there perhaps may be an evidence to rely on Urolupus regimen as well as on mycophenolate rather than opting to high-dose regimen. overall, in all these, in all arms, on all these different studies, the low-dose cyclo, the high-dose cyclo, the high-dose cyclo, again, complete remission rate at 6 months was disappointing, not exceeding 25%, between 21 to 25%, and were similar over all therapeutic options. After we had a period, 6-month period of initial induction therapy with an induction agent plus a corticosteroid, which therapeutic response would you expect? Either one of two responses. First, complete renal remission or partial remission, complete response, partial response, or no response at all, and encounter a 12-month period, no complete or remission or partial remission. First, to define a complete remission, complete means complete. So it means that there will be resolution of proteinuria to below the half gram a day level based on 24-hour urine collection. And serum creatinine stabilized to not more than 10 to 15% of the previous baseline. And again, we hear not only discussing a patient, a naive patient with first diagnosis of nephritis, but rather a patient with lupus nephritis flares. So the baseline may be the baseline before developing systemic lupus or the baseline before developing a lupus flare. The partial remission will be 0.5%, 50% reduction in proteinuria to a month, but typically this is not uncommon. Typically it usually takes more than 12 months to develop, and in clinical scenario we may give the patient up to 18 to 24, 1.5 to 2 years to check for a complete remission. And here I'd like to highlight that in studies assessing for predictors of long-term renal outcomes, proteinuria with protein excretion less than 800 milligram, or let's say less than a gram, to remember the figure, less than 800 milligram a day at 1 year was the best indicator, the best predictor, if not the only predictor of good long-term renal outcome. And I'd like to highlight, I'd like you to remember this point because this point may give some dilemma when discussing the membranous presenting with subnephrotic proteinuria. If the patient responded, we will go to the next phase. In patients with complete or partial response, the maintenance phase or the extended therapy phase, which will last for even more than 2 to 3 years. The exact duration is not evidence-based, it's unclear, and will be considered in patients 5 to 7.5 or less than 5 to 7.5 milligram during the maintenance. During the induction, it was brought down to these levels, and during the maintenance, we will further taper the steroids. Plus another agent, which will be first choice MMF. First choice is the statement in the most recent 2020 KDIGO guidelines. They considered MMF as the first choice maintenance therapy. 1 to 2 grams a day is azathioprine, which is going to be reserved to individual indications in patients who are not tolerant to MMF, who don't find MMF, don't afford MMF, or in pregnancy. 1.5 to 2 milligram per kilogram a day. And lastly, if the patient does not tolerate mycophenolic acid derivatives, azathioprine, tacrolimus with a trough level 4.26, cyclosporine A60 to 100 trough level, and mesoripine, which is a proliferative with Japanese experience only, may be resorted to. And this is the statement in the KDIGO draft. Azathioprine is reserved, as we said, to the patients who don't tolerate the mycophenolic acid derivatives, don't have access, or who consider pregnancy. A clinical question or a clinical point that we may encounter when shifting a patient from the induction phase to the maintenance phase, when to start the maintenance therapy. If the patient had IV cyclophosphamide as initial therapy, we will start the maintenance therapy ESA or preferably MMF 2 to 4 weeks after the dose of cyclophosphamide. And if MMF is the initial therapy, we will just continue and start tapering down the dose to the maintenance level over time. And now to give a hint about glucocorticoid therapy. We should put in our mind that we target the lowest possible oral prednisolone dose. That is, now we assume that the renal disease is limited and the lowest possible pred dose sufficient to control the extrarenal symptoms will be targeted. And in asymptomatic patients, we should slowly taper off prednisolone, and there are one of two approaches. First is that we will continue tapering down prednisolone. Even in patients reaching the 5 milligram a day, we will taper after that every month by 1 milligram a day. Or some physicians prefer just leaving the patient on this dose or a lower dose and leaving the patient forever on that dose. In the most recent KDIGO guidelines, it's recommended to discontinue steroids or to consider discontinuing steroids if the patient had complete remission, and I stress complete remission, for 12 months. During the maintenance phase, if complete remission has not been achieved after 12 months of maintenance therapy plus 6 months of induction, it's a total of 18 to 24 months. We may consider a repeat kidney biopsy in this stage. And while maintenance phase, maintenance therapy, this is number one. Number two, while maintenance therapy is being given, is being tapered, if kidney function deteriorates or proteinuria worsen, just a worsening or deterioration, we will go step back to the previous level of immunosuppression that controls lupus nephritis. Rapidly going through the evidence comparing azathioprine versus MMF, patients that were included in the Aspiriva lupus management study MSc and induction, looking at the induction therapy, were continued or were randomized on to maintenance therapy of MMF versus azathioprine, and this study was published in 2011. If you look at the graph, mycophenolate mofetil achieved significantly better response rates than treatment failure free of better probability of being free of treatment failure and better probability of being free of renal flare than significantly. And the conclusion was that MMF is superior to azathioprine in maintaining renal response to treatment with no in patients who had either MMF or IV cyclophosphamide, whatever. However, just 1 year before, in 2010, the results of maintained nephritis trial was published, and there was no significant difference between azathioprine and MMF regarding the percent free of renal flare over the full period of up to 16 months. And the conclusion was that numerically fewer renal flares in MMF treated patients, but not significantly, did not reach statistically significant, and not able to demonstrate superiority of MMF. This meta-analysis showed that there was an evidence that MMF was favored just numerically, but no statistical significance in favor of better outcomes with MMF in contrast to azathioprine. Again, the same. And consistently, the same findings were here apparent here in this meta-analysis published last year, where MMF was okay. It was more effective than azathioprine as maintenance therapy, but this again did not reach statistical significance, and the MMF group had lower risk of leukopenia than azathioprine. So the most recent recommendations relied upon the evidence and relied upon this evidence of having fewer relapses or better outcome with MMF despite not achieving statistical significance, a lower risk of side effects, and recommended MMF as the first choice therapy. Maintenance therapy, sorry. If we could reach remission, well and good. However, if we could reach remission and could have the wolf or lupus dormant like that, well and good. The question that will arise now is that whether immunosuppression will continue for life or not. There is no evidence-based guidelines to recommend when exactly to stop therapy or what to do with therapy over the life of the patient. However, the bottom line is the overall therapy duration should be at least 3 years, 36 months, initial plus maintenance. If the patient achieved partial remission and couldn't achieve complete remission, the therapy will continue indefinite. There is no thinking about ending or stopping therapy. However, in patients who achieved complete remission, at least 1 to 1.5 years should lapse before, or therapy should continue for 1 to 1.5 years before considering therapy withdrawal or therapy cessation. And this was stated even since the last 2012 KDIGO guidelines. The problem now is when we face an angry wolf in patients who don't respond to initial induction therapy. Again, back to the to this algorithm, when we give an induction therapy and we encounter the worst case scenario, worsening disease at any point, no response, and even worsening of the disease at any point, we should first think whether the patient takes therapy. We should verify adherence to therapy, firm adequate dosing, perhaps by having levels of the drugs that the patient take. And if we are confident that the patient is adherent to therapy and taking his therapy in adequate doses, then we should think about having alternative induction therapy. What we mean by alternative induction therapy, the first line therapies, MMF and Cyclo, we consider another alternative first line therapy. If the patient don't respond and assumed to have refractory disease, then we should consider, and previously or earlier, we should have considered or thought about repeating diagnosis and confirm the histologic activity versus chronicity, whether this worsening is due to scarring and chronicity or due to activity, and to evaluate complicating factors like TMA. In the course of systemic lupus erythematosus can develop TTP, can develop antiphospholipid antibody syndrome with worsening kidney function or worsening kidney condition. And alternative therapeutic options will be considered now. In the form of number 1, multi-target therapy, plus a calcium inhibitor. And again, this line was considered, had an advantage in the most recent KDIGO guideline to be put just after the first line in therapy.
دكتور علي. دكتور فيصل.
معك.
I am very happy that you joined this meeting, Dr. Faisal. Until we have the voice of Dr. Ali, I like to hear from you. I think the situation in Saudi Arabia and in the Gulf is different, and this opens the horizon for personalized medicine. Because, as you know, the biological treatment, there is a big debate of the use of biological therapy for treating active lupus nephritis. But I think on a case by case, the biological treatment may solve a problem. I want to hear from you about this point.
Yes, I am sure. You know, lupus is an important disease, and it looks like sometimes it's become like epidemic, and sometimes because we may have some a lot of patients in one time coming from everywhere. And again, the people who share in the management, either nephrologist or rheumatologist or physician. But we start to have some people who accumulate, deal with such patient, and the biological treatment is, as you mentioned, is very important also. But still, the same protocol which our colleague is mentioned, we are using it and we are practicing it daily with our patient, and it seems to be that is very effective with them. He didn't speak yet about rituximab, but myself, I use rituximab with many patients and with a good outcome.
I want just to clarify a point regarding rituximab. If we treat a patient who has nephrotic state, we should be careful because the patient may need bigger dose of rituximab, because rituximab can be lost in the urine with proteinuria. So we may need a larger dose. Sometimes the patient cannot tolerate immune suppressive drugs or refuse immune suppressive drug. For these cases, I may use biological treatment as the first line for this patient. So if we speak about the guidelines are just helping us to put algorithm of management. And for each patient, I am as a treating physician, I am totally responsible about selecting the best treatment for this patient. So as you mentioned, thanks for mycophenolate mofetil, because the females in Saudi and in Egyptian, and some Egyptian ladies, especially those who are well educated, refuse to use cyclophosphamide, although the dose of cyclophosphamide that we use currently in treating lupus nephritis is minimal. In the early 90s, we used the big dose, 1 gram every month and for 1 year, and then every 3 months. Heroic dose of cyclophosphamide were taken at that time. Nowadays, we use just the Lupus protocol, 500 milligram every 2 weeks for 6 doses, so almost 3 gram. But you can find the lady refusing completely, or the husband completely refusing the idea of using a drug that may lead to infertility. And in the Western community, they prepare as adjuvant treatment to the drugs that preserve ovulation. So this is why I think at your country and many countries, there is a fear from using cyclophosphamide.
Yes, still cyclo and even steroid.
Yes.
Steroid therapy is the people started to avoid. That's why the uses MMF and probably Prograf and cyclosporin. Sometimes you have to move toward this drug in order to avoid using cyclophosphamide or steroid.
Yes, suppose that we started with mycophenolate mofetil, as Dr. Ali mentioned, and the patient is tolerating or witnessing significant side effects. So we can think of other drugs like calcium inhibitors, like biological treatment. So for the guidelines, both broad lines, but at the end of the day, I select the best for this patient as a personalized medicine. I want to ask you, Dr. Faisal, about, do you use a 3 gram mycophenolate mofetil? Because sometimes the patient doesn't respond to 2 gram protocol, and when we increase to 3 gram mycophenolate mofetil or equivalent mycophenolate sodium, the patient may respond. Do you?
Well, no, actually, we, as myself, my experience, and also my colleague, usually we use 1 gram BD. Yes. It's not, if we exceed it, the gastrointestinal problem will start to appear, and the patient even doesn't like to any medication. But still, myself, if it is aggressive SLE, rituximab with my patient have a very good result. I usually give around 1 gram as one dose, and then I see B lymphocyte, B19 or 15, and after a couple of weeks, and then we give the other dose. And for me, it seems that it even all the manifestation of SLE start to disappear after a week of giving rituximab. So maybe you don't like, but myself, in my experience, it seems to be it's good work, good with me.
I like it, although the randomized control study, and I think Dr. Ali will mention this sector in his presentation, doesn't confirm a beneficial effect, but in Japan and other countries, it works well. And worked with me in some cases. The major problem here in Egypt, the major barrier is the cost. But I want to add a point here. I don't recommend it nowadays at all for treating patients with lupus nephritis. Why? Because of lymphopenia that persists for more than 3 months up to 6 months. In the era of COVID, and we are afraid of COVID, we don't like, this is one of the drugs better to be avoided in this era of COVID. After COVID, I may use it again and again. Dr. May, do you like to add something?
I think Dr. Ali is giving a very comprehensive talk, and we'll still want to hear about what he's going to say about rituximab.
Dr. Ali is one of the best, and he did a very nice effort in the presentation. The major problem was the internet. The net is not so strong, the signal is not strong. This is why the sound is not clear in all the presentation, but the presentation is very clear, very nice, and the efforts are very, very appreciated.
Thank you, Dr. Z. If the sound is not clear, I can look for
yes, please. Sound please.
And use, perhaps it may yes. make things better.
Please use it.
Just a second.
Okay. So Dr. Faisal, again, to discuss with Dr. Faisal, because Dr. Faisal is one of our beloved professor in the Arab country, and I know that he has a very nice experience. Treating lupus nephritis is different from country to country. It seems that we are speaking about different disease. So lupus in Saudi is different in lupus in Egypt, different in the United States. This is why I advocate the experience and the publications and or searching or collecting the data for each country. And even mortality is different from country to country. What's your point, Dr. Faisal, about this issue?
Well, I think you are right. It is different, but in Saudi, you know, we have different nationality and different ethnic group. And that's why I may have sometimes some Pakistani ladies who had SLE, next day Saudi one, and after that some other nationality. So we have from different nationalities actually. It's not only in Saudi populations. We, as you know, we are 32 million, 20 Saudis, 12 non-Saudi, and this 12 is from 51 countries. So we can face a lot of those patients coming from different countries, and we are treating them. Even we have a lot of community who had SLE and been transplanted, and we are following them. So those are challenging patients, actually, especially if we go for clotting for patients who may develop clots after transplant, how to deal with them, how to continue their medication post-transplant. We have a good number.
I think we will discuss this point after Dr. Ali finishing his presentation. The point I just want to finish by the issue of lupus is different from country to country. Even if in Saudi Arabia you have different nationalities, but they are living in one community. There is a problem in genetic, I know, but there is a problem in the environment. Even in the disease is different from season to season. So it is different in winter than summer. In summer, the disease is aggravated by the sun. And if you are in sunny country, and the Gulf, I think almost 10 months in the year, sunny and hot temperature, it is completely different if we live in United Kingdom or United States in some areas with very cold weather. So yes, there is genetic background that dictates the disease and predict the prognosis, but also environmental, even food, and a lot of issues control the disease and make a noise from country to country. I prefer to leave the mic to Dr. Ali Shendi to complete his journey in managing lupus nephritis. It's quite difficult to speak about this disease in one presentation, but Dr. Ali will do his best. Dr. Ali, تفضل.
I'm trying to make the lupus nephritis as a journey, as you said, Dr. Hussein.
Raise your voice, please, Dr. Ali.
All right. Do you hear me now clearly?
Yes, yes.
All right.
Go ahead.
Back to the last slide, to start from the patients with refractory disease, and we tried more than one first-line induction regimen, the MMF, the cyclo, in patients who didn't respond to the first line. We tried the second line, and if the patient deemed refractory, not responding, we considered a repeat kidney biopsy to check for activity versus chronicity, and we said that we perhaps with alternative therapeutic options, the multi-target therapy or the B-cell depletion therapy. Now to give a hint about the B-cell depletion therapy, the rituximab. First, it's used off-label. It's not licensed for use in lupus nephritis or in SLE in general. Would we opt to use rituximab in these patients? We may consider them, number one, in resistant cases, and this depends on just observational data with no randomized control trials or no strong evidence to support this. And the second point, perhaps, if we, in patient who is refractory to all maintenance therapy, we can try rituximab as a maintenance therapy after induction. Rituximab failed to prove efficacy over placebo in this randomized double-blind placebo-controlled phase 3 trial that used rituximab or rituximab in comparison with a placebo added to the standard of care therapy, the MMF and corticosteroid therapy. The study was published in 2012, and in this study, if we look at this diagram, patients with complete renal response rate, patients showing complete remission were just alike in the two groups, the MMF with placebo versus the MMF with rituximab. Perhaps there was just a numerical and non-significant increase or higher rate of response, partial response, not complete response in patients receiving rituximab, but this did not achieve statistical significance and couldn't support using rituximab or approving rituximab for clinical use. Over the weeks in this patient, there was no difference. If you look at these two lines, there was no difference in complete remission rate between rituximab and placebo-based groups. And in overall response rate, the response was numerically, but again, not significantly better with rituximab, supported by the improved partial response rate, again, non-significantly. When we divide or look at the subgroup analysis of different ancestries in this study population, the white patients in the two groups did quite alike, and the Hispanics as well. Black rituximab did better, but again, non-significant. However, in refractory lupus nephritis, this meta-analysis was published 2 years ago, looking at the different studies that tested rituximab as a therapy, and all were observational studies in refractory lupus nephritis. The meta-analysis showed that there was significant response in favor of using rituximab, adding rituximab to conventional therapy in patients who did not show a response to conventional therapy, both in lupus nephritis and in patients with SLE with other features of remission or showing or other features refractory to therapy other than the lupus nephritis. And this was the finding of findings. This was the conclusion of findings demonstrate that rituximab therapy achieved significant clinical efficacy and favorable safety profile in SLE and the lupus nephritis patients refractory to conventional therapy. Now, to have a say or a go through the multi-target approach in lupus nephritis using multiple weapons to target the lupus patient, the rationale for this therapy or the idea of this therapy was introduced first through the study in 2015 that was done in China. And the idea was that if we are used to have multiple therapies in a transplant patient, MMF and antiproliferative and calcineurin inhibitor and corticosteroid, why not to try this approach in patients with lupus nephritis? Having theoretically lower incidence of side effects and better outcome. In this study, the induction treatment of lupus nephritis with multi-target therapy resulted in significantly better overall response compared to the IV cyclophosphamide with the high-dose regimen at 6 months. And the multi-target therapy here used tacrolimus 4 milligram a day and MMF 1 gram a day, just 1 gram a day, compared to cyclo the MIH regimen. Again, this was in Chinese population, and the study suggested that the multi-target therapy is superior to cyclophosphamide. Again, the side effect profile was similar. It can be considered as an alternative to conventional therapy for induction treatment of lupus nephritis. They continued through the maintenance phase. The same group continued their patients. Those who received induction multi-target therapy continued on multi-target therapy through a maintenance phase, tacrolimus 2 to 3 milligram a day, and MMF at a lower dose of half to 0.75, 0.75 gram a day, and PRED 10 milligram a day, lower doses of the drugs over a maintenance period. And although they didn't find statistically significant difference between the groups, they assumed that the multi-target therapy could achieve numerically better relapse-free rate compared to the azathioprine. That the patients who received initial induction with cyclophosphamide were maintained on azathioprine, which is weaker than MMF, and have a better adverse event profile. And they assumed in the conclusion that the use of multi-target therapy as maintenance therapy may show lower renal relapse rate and fewer adverse events, and thus it can be an attractive option to treat a patient with lupus nephritis. And this study was published in 2017. During the same period of time, this study, ORA-LV study, which was published in 2018, EPUB ahead of print, and 2019 in Kidney International, looking at the study was a randomized controlled double-blind study looking at the safety and efficacy of the new CNI voclosporin versus placebo in patients with active lupus nephritis on a background of the standard therapy, MMF and corticosteroids. They tested initially in this study, phase 2 study, 2 dosing regimens of voclosporin, the lower dose and higher dose in contrast to placebo, and look at primary endpoint, complete renal remission at 6 months, significantly higher low dose voclosporin compared to placebo. And again, the secondary endpoint at 12 months, significantly better response rate, even double the response rate, or the complete renal remission rate when compared to placebo. This is attractive indeed. And however, the drawback here is when we looked at the adverse event rate in both voclosporin groups, there was more serious adverse events compared to placebo and more deaths in the low dose group compared to placebo. And this a safety issue on this regimen of therapy. However, the phase 3 study that was called the Aurora study was running comparing a low-dose voclosporin versus the multinational randomized controlled placebo-controlled trial comparing low-dose voclosporin to placebo, and the results were announced in a National Kidney Foundation meeting last March, in March 2020. And at that time in Medscape, this title was published that this is the dawn of a new lupus nephritis treatment after the Aurora trial. And few days, just 1 week ago, this voclosporin-based therapy was submitted to FDA approval. And the results of this study, phase 3 study, showed no increase in side effects, no warning about the increase in serious or side effect compared to placebo in the voclosporin group, and significantly higher overall complete and partial response rates for induction with multi-target therapy based on voclosporin, MMF, and steroid when compared to placebo or compared to the conventional therapy of MMF and steroids. So we are perhaps awaiting FDA approval for this drug over the next year of this therapeutic regimen for SLE. We now spoke about proliferative forms of lupus nephritis from induction to maintenance and the future of therapy of perhaps potentially the future of therapy of proliferative forms of lupus nephritis. Now a word about the rarer form, the membranous form of lupus nephritis. I'd like to highlight just 2 points. The first is that speaking about or looking at lupus membranous nephropathy, we are not waiting for remission like we wait in primary membranous nephropathy. We are not anticipating the context of a lupus, so we don't anticipate spontaneous remission. This is one point. The second point is, again, I remind you that the best and even the only correlator or predictor of good long-term renal outcome is a 1-year proteinuria of less than 800 milligram a day. Then to an algorithm to treat a patient with class 5 lupus nephritis, there are one of 2 options. The first is that the patient has been or worsening kidney function. So there is an indication to target lupus nephritis with immunosuppression, and the immunosuppression options here are either MMF 2 to 3 grams a day, plus or minus corticosteroid. Perhaps we can give low-dose corticosteroid to treat extrarenal SLE, CNI, cyclosporine or tacrolimus, that here in membranous lupus nephropathy is number 2 before even cyclophosphamide and corticosteroids. And lastly, the multi-target therapy, MMF plus CNI. Perhaps we may mention azathioprine in patients who don't tolerate all these drug regimens or don't have access. The first point here is that corticosteroids are relied upon mainly to treat extrarenal SLE. CNI had an upper hand, and the multi-target therapy has a strong place. The other option is that the patient has subnephrotic proteinuria less than 3.5 grams a day with normal serum albumin, preserved kidney function, no clinical manifestation. So the classic recommendation is to just reserve immunosuppression to treat the extrarenal or non-renal SLE. However, some physicians will consider immunosuppression to treat class 5 if proteinuria is more than a gram, because having proteinuria less than a gram correlate with or predicts a better long-term renal outcome. So at this cutoff value between 1 and 3 grams a day, there is a debate whether to give immunosuppression or not. I assume that a category of patients with such level of proteinuria and membranous nephropathy in the context of lupus is very rare to find, or very rare to find and to continue on that level of proteinuria for a long time. So that close monitoring, I expect that the patient will progress in a way or another. So that close monitoring is recommended to detect worsening of disease and to evaluate for transition, if it occurs, to a proliferative form of lupus nephritis, which will present with a deterioration in the clinical scenario. If the patient, now we have spoken almost comprehensively about all aspects of management, all the journey from the beginning to the end, all forms of lupus, and if the patient developed a relapse, not just a deterioration or increase in levels, flare in lupus, it's suggested by KDIGO to resort to the initial regimen which induced in the initial in order to induce a second remission. This is number 1. However, if this regimen was, for example, repeated courses of cyclophosphamide, and this will put the patient at risk, so we should change to another first-line therapeutic option in order to induce remission this time, and we should consider repeat kidney biopsy as we discussed before. What's the evidence behind hydroxychloroquine? We agreed that hydroxychloroquine should be recommended for all patients with SLE. Modulatory activity, decreases interferon alpha with downstream cytokines, and it has an anti-inflammatory, anti-thrombotic effects. And there is evidence in the systematic review. I'll not go into every single evidence in detail, but in the systematic review, there is evidence that hydroxychloroquine help reduce SLE activity, help induce and maintain a remission, reduce mortality. It has protective effect on thrombotic events, so there is a rationale to give hydroxychloroquine in every patient, and the dose will be 5 milligram per kilogram a day, maximum 400 milligram. 2 points I'd like to remind you with. First, hydroxychloroquine is safe in pregnancy, and in a pregnant pregnant lupus patient should continue throughout pregnancy. And the second point is that beware of the toxic effect of hydroxychloroquine on eye and the eye, on the retina, on the macula in particular. Eye examination should be done at baseline, and then in the era of COVID-19, we can't speak about lupus nephritis without discussing how these patients can do in this area, in this era. The worst scenario is to have a patient with lupus flare in the context of a COVID pandemic. And even the worst of this scenario, or the worst of this scenario, is to have a patient with COVID and a lupus flare at the same time. So first of all, we should apply strict preventive measures to avoid COVID infection in patients with lupus nephritis. In patients with poor immunity taking immunosuppressants, we should recommend not only social distancing, but even isolation and even shielding in patients on immunosuppression. Shielding means that not to go outside their homes, not to meet anybody, not to deal with anybody outside the home, outside the and to continue lupus treatment. And as Dr. Hussein mentioned earlier, we should be cautious when starting new therapy, especially the long-acting ones. And we should here avoid those agents that act for a long time, like rituximab and cyclophosphamide injections. When the patient develops signs of infection, we should pause immunosuppressives and apply sick-day rules for steroids. The British Society of Rheumatology has announced this risk categorizations for patient, and to summarize, this risk category gives a score to the patient. If the patient is receiving one of the immunosuppressants, cyclophosphamide, azathioprine, mycophenolate, cyclosporine, any immunosuppressive, he will be given 3 score, which is 3 or more. If the patient has 3 or more, the patient has to shield, to keep at home and not to deal with anybody outside the narrow circle of carers. If the patient had scored to either self-isolate or maintain social distance, and score 1 or less, hydroxychloroquine, for example, give a score 0 to maintain social distance. And when we mention hydroxychloroquine in the context of COVID, a question arises. Multiple institutions have put an algorithm to follow. These are available online. A question arises now: was hydroxychloroquine protective in patients with SLE on hydroxychloroquine for a long period of time? And the data from case series, just letters in this Annals of Rheumatic Disease Journal, comparing patients with SLE who received antimalarials versus those who received who didn't receive antimalarials or who were not on antimalarials. The answer to the question is simply no. Hydroxychloroquine didn't prevent COVID-19, nor its severity modified its severity in patients with SLE. The last point to discuss in my presentation today is, what if our patient wishes to get pregnant? And here there are just few recommendations, few points to follow. Number 1, the patient should avoid pregnancy. She is banned from pregnancy if she has, or so long she has active disease or during tapering therapy. This is number 1. At least 6 months, and preferably up to 12 months of quiescent lupus, dormant lupus, should be before thinking about pregnancy. And before planning for pregnancy, we should leave 3 months, or before pregnancy by at least 3 months, we should modify therapy to avoid the teratogenic drugs. And when we mention teratogenic drugs, we have 2 drugs that pop up in mind. Number 1, MMF, and the number 2, the kidney protective agents, the RAS blockers. We should, if we plan for pregnancy, we should change, before speaking about changing MMF should be changed to azathioprine, and we should consider maintaining hydroxychloroquine throughout pregnancy, starting aspirin as early as possible, better before the 16th week. Low-dose aspirin give protection against preeclampsia, low birth weight, or low
wait for gestational age of the child, give protection against lupus flares, against thrombosis, etc. The drugs that are considered safe in the context of pregnancy: oral corticosteroid, hydroxychloroquine, the azathioprine CNIs, and rituximab is warned against because it may cause fetal B cell depletion. This is for the patient who has who is in remission and wish to get pregnant, and if the patient did well throughout pregnancy, well and good. But if the patient developed lupus flare during the pregnancy, it is assumed all of us will be afraid or will think many times before going to take a biopsy from the patient, but it may be safe to have a biopsy up to 20 weeks of gestation if it is necessary, clinically indicated, highly indicated. And the therapeutic options now, we mentioned the safe drugs will be, we will be restricted to these groups of drugs. First, hydroxychloroquine in all patients, it's okay. Number two, corticosteroids, but we are aware of that corticosteroids may increase the risk of gestational diabetes. It may increase the risk of cleft palate given in the first trimester in the baby. The two drugs that are safe is azathioprine and CNI. We may choose one of them, or if the patient presents with a lupus flare, severe disease, perhaps we think about combining both in a multi-target regimen. Azathioprine, CNI, and corticosteroids. In severe cases, resistant cases, where we cannot give MMF, cyclophosphamide, perhaps rituximab, we cannot give rituximab as well. We may resort to IVIG, resistant and or severe cases at last. This was my last slide. I finished my presentation, and back to questions that we elicited in the first. I'm sure that all of you answered them in the beginning. All the sentences were wrong. A kidney biopsy is indicated nearly in every patient with lupus nephritis. Induction therapy with MMF yield higher remission rate than cyclophosphamide. Both were comparable. Azathioprine were not more effective than MMF, by contrary, right. Class 5 lupus nephritis treat with immunization regardless of kidney function and level of proteinuria. We should consider kidney function and the level of proteinuria when treating membranous lupus nephritis patient. And there is an area of debate here we discussed earlier. Hydroxychloroquine recommended throughout the course of SLE therapy and even during the pregnancy.
If you allow me, Dr. Ali, Dr. Ali, the previous slide, please.
Okay.
The previous slide again.
Right.
Because the first statement, kidney biopsy is indicated mainly, I think it is indicated, and because we shouldn't stop at the clinical diagnosis. Lupus nephritis means biopsy. If there is proteinuria, we do biopsy. So the sentence needs some improvement to agree about. So I agree for every case, de novo case, to have kidney biopsy in lupus patient to know where we are, except if the patient is in bleeding risk, high bleeding risk, or presented with small kidneys. This is my point.
Will be, yes, thank you, Dr. Hussein, for the addition. The improvement will be to add, if the patient is de novo, if the patient have a lupus flare, we may or may not need, we may think about...
No, not pregnancy, not in pregnancy, Dr. Ali. The next slide, please. Next slide.
Indicated mean? That's fine. Yes.
Yes. Kidney biopsy is indicated. That's it.
Yes. All right.
So if the patient is referred to nephrology, he will be referred because of proteinuria. If proteinuria exceeds half gram,
yes,
this is an indication for biopsy. Because
yes,
as you mentioned, because there is some guidelines stating 1 gram, but as you mentioned, 800 milligram is a risky and a predictor of poorer outcome. This is why kidney biopsy is indicated for de novo cases diagnosis. Repeated biopsies for guiding maintenance therapy is still investigational, and there is some studies recommending repeating biopsies before stopping immune suppression altogether. So this sentence, I agree with biopsy, but with improving the sentence.
It's wrong sentence. It's
yes. Okay.
Yeah.
Okay.
This my last slide, the page of the category guideline. I invite all of you to start reviewing the chapters of the guideline I'll start reviewing the lupus nephritis chapter. It's available on the KDIGO
Okay.
site. And thank for your attention and for listening to me tonight.
Thank you very much, Dr. Ali Shendi, for your excellent presentation and the good efforts to make it simple. I think it is very difficult to discuss everything about lupus nephritis in one presentation. And I think we have 10 to 15 minutes of discussion just to hear from the audience and the professors with us. Any comments about the presentation? Dr. Saeed Khamis, if we want to hear from him, because he is joining the meeting from the beginning. Dr. Saeed.
Yes, Dr. Hussein. Good evening.
Yes. Do you have any comments? Do you have any
Dr.
comments?
Saeed,
Yeah, just one comment and one
Yes.
question. Just
Yes,
very short.
please.
Dr. Saeed.
Yes, please.
Hello, Dr. Ali. How are you?
Okay. What is
Thank
your
you for
comment?
the elegant presentation, as usual. Just to have one comment.
Yes.
The comment is, if you remember, 15 years back or more in the NDT, it was a publication or paper regarding a review article. It was regarding the anti-C1q antibody. It was the title, very attractive title. It stated, in the absence of C1q antibody, you can rule out something like this. You can rule out lupus nephritis. And we were very happy at that moment that we are going to towards the era of biomarkers and non-invasive techniques and so. So after that, this issue was disappeared almost completely. That's number one. Number two, regarding lupus nephritis, okay.
Regarding biomarkers, Dr. Saeed, regarding biomarkers for diagnosis and predicting prognosis of lupus nephritis, although it is attractive, we have more than 100 biomarkers in the serum and the urine.
Yeah.
Although they are attractive, but up to this point of time, nothing is perfect, nothing excellent. And this is why biopsy is the gold standard for diagnosis for lupus nephritis. And the biomarkers are still for research purposes.
Okay, thanks. Second point and the last one is last year I faced one case of severe lupus nephritis, and it was a lady in 35 years old almost. And unfortunately, the patient went into severe convulsions. She was started on steroid and MMF. And unfortunately, this convulsions was very resistant to all measures. And we consulted the neurologist, and he ruled out all the neurological causes of these convulsions and so.
Dr. Saeed,
yeah.
Was she treated with mycophenolate mofetil for a long time?
Yeah, that is the issue. I stopped the mycophenolate mofetil when I reviewed the medications and so. And fortunately, the convulsion stopped, and I realized that the cause behind this, it was the MMF at that moment. Despite at that moment,
Dr. Saeed, I want to congratulate you about this case, because last year there is a case report about convulsion accompanying treated lupus nephritis by mycophenolate mofetil, and when they did for the case mycophenolic acid level, they find it toxic level. This is why nowadays I am a little bit convinced by the role of leveling mycophenolate mofetil. And since 4 years, I delivered a presentation against mycophenolate mofetil level doing, to 2D or not 2D, to drug monitor or not. My answer was not to monitor, and it is enough to follow clinical, CBC, diarrhea, etc. But if the level is available, the problem in mycophenolate, trough level is not predictive of the outcome, and we need to calculate area under curve. Even though, if we look at the trough level, it will give a good idea. If we find it very high, this may explain convulsion. Because if you have convulsion and you don't diagnose the case, you may think of plasma exchange and IVIG and a lot of treatment for thrombotic microangiopathy accompanying lupus nephritis.
Fortunately, she was okay after I stopped this MMF regarding the convulsions, really.
But I think you didn't measure mycophenolic acid level for this case.
No, unfortunately, no. But I made it empirically. At that moment, I stopped it empirically.
Last year, there is a case report about the high mycophenolic acid associated convulsion in a lupus treated patients.
Okay, thank you. Thank you.
Thank you very much.
Okay,
Dr. Naguib Abu Sma. Dr. Naguib. Do you have Dr. Naguib raise his hand? Where is he? Yes, unmute. Dr. Naguib. I unmute you, but you don't accept unmute. So let us go back to Dr. Faisal, because I like the discussion with an expert like Dr. Faisal. I think one of the important points that's missed in this presentation is antiphospholipid antibody. And there is a study in Egypt investigating more than 1,000 cases of systemic lupus erythematosus, found that antiphospholipid antibody is positive in almost 30 to 40% of the cases. And as Professor Faisal mentioned, when the presentation was interrupted, that the best marker and the best serology and the most recommended serology before accepting transplant lupus case is antiphospholipid, because kidney graft may thrombose if we don't pay attention to antiphospholipid. Dr. Faisal.
Yes, I agree, Dr. Hussein. Prof. Hussein, actually, first I would like to thank Dr. Ali for his excellent talk. And actually, he didn't mention that. I don't know why. Maybe it doesn't come through, or he may have more slides about this. It's very important about the coagulation problem of those SLE cases. Yes. Especially when we go for transplant. Usually, first step to do it is to do the test, and if the test is positive, we have to be very cautious. The patient may get thrombosed in OR. So even so, with the negative result, we still give some sort of anticoagulant, intraoperative and post-operative as well. And even at home, I give myself aspirin as a prophylactic for those patients. So it's very important to know this in SLE case, especially with transplantation.
I thank you, Professor Faisal, for this point, because this is what we say in every clinical round with residents here. Before transplantation, I don't like to know antinuclear antibody, but I want to know antiphospholipid antibody test is positive or negative. And yes, we follow a very simple algorithm. If antiphospholipid testing is positive, then we should ask ourselves, does the patient have any history of thrombosis, DVT, closed fistulae, or any thrombotic event, thrombophilia? If he has clinical thrombophilia plus positive antiphospholipid, now we think of long life anticoagulation, to start heparin before transplantation and to continue after that by oral anticoagulant when kidney function stabilizes. If the patient has no thrombophilia, no clinical thrombosis, but positive, only positive serology for antiphospholipid, we'll continue indefinite for aspirin. This is a very simple approach. What's your opinion about this approach? I think it's practical.
This is the same, actually, the same practice. This is the ideal practice for SLE cases who is going for transplantations.
Yes, yes. Dr. Naguib, do you like to ask or to share? Where is he? I'm sure he disappears. Okay, we can take another question or another point.
There are some questions in the
yes, please, please. Tfaddal.
What do you think about the benefit of protocol biopsies in lupus nephritis? Some cases may have serological and clinical remission, but at the pathology level, they may still active.
Yeah, very nice question and very nice point. And it was addressed early this year in one of the articles published in, I think, in Kidney International, if I'm remembering well, a study from South America. The authors did biopsy even for subsequent biopsies to show, to be sure and assured that there is no active lesion when they think of tapering maintenance immune suppressive therapy. And maintenance immune suppression should be maintained if there is pathology. And it is very risky to stop immune suppressive drugs while there is activity in the pathology. So they repeat every now and then up to 4 biopsies. In our practice here, we have a PhD thesis in nephrology to follow the clinical remission by protocol biopsy. But as you mentioned in your presentation, all of us agree about the first biopsy, but we can disagree about protocol biopsy if there is complete remission in clinical. But if there is flare, we can do rebiopsy to know if we are dealing with chronic case or active case necessitating adding immunosuppression. So this is my point. So it depends upon the convincing, and we are waiting further evidence from here or there to support the protocol biopsy for patients who have full remission.
I have a comment, Dr. Hussein. If
yes,
the
please.
patient do have a complete remission, there is no point to do protocol biopsies every now and then while the patient is okay and maintaining his therapy, unless we are thinking about stopping therapy
yes.
altogether.
This is the rationale.
This is the point that we stop. That we have to stop and look at the biopsy to see how the histology is. Before stopping,
if you have clinical remission plus pathological remission, this means that you are in a case of quiescence. So this will assure you and support your decision to stop immune suppressive drugs.
While in patient on partial remission, if the patient maintained the partial remission, we may.
Yes, we may do biopsy here.
And if the patient doesn't go, we tend to do a biopsy. This is an indication to have a biopsy.
Yes, maybe in the algorithm you mentioned from CJASN since a couple of years, yes, it is very valid to do rebiopsy because you may find partial remission because of severe chronicity and no active lesion. Yes. So this will guide us for treating the patients by immune suppressive drugs. And I want to tell you my experience here or our experience here at Urology and Infection Center by the use of IVIG in resistant cases. It doesn't work with us. Also, the experience of using lupus rituximab in resistant lupus nephritis, also it is not good with us. But it works well when we decide on a personal basis, case by case, for the patient preference to use rituximab as de novo treatment. So, but Professor Faisal Shaheen mentioned that the rituximab works well with him in Saudi. Do you have another comments, Dr. Faisal?
No, not at all. Okay. No.
Okay. Dr. May? Unmute. Yes. Dr. May.
I didn't have a chance to say hello to Professor Faisal.
Yes.
We are very much enlightened by Professor. Can you hear me?
Yes.
Yes, I can hear you. I can hear you. Thank you very much.
To have you joined our meetings, and we are really enlightened by your discussion. Thank you very much. And I hope
you. Thank you. I appreciate it. Thank you very much. Thank you. Thank you, Dr. Ahmad.
And I take the opportunity to invite Professor Faisal with us tomorrow, 8 p.m. We will discuss very hot issues about the immune suppression in transplant patients, drug-drug interactions, and I start with COVID-19 treatment and immune suppressive, then antimicrobial, and so I prepare a very hot, delicious session about drug-drug interaction in transplant and the use of immune suppressive drugs. So please join us tomorrow.
I am waiting for that.
Thank you very much. Thank you. Thank you.
Thank you.
I want to thank
Dr. Ali. Yes.
Ali, it was really very comprehensive.
Thank you, Dr. Nani.
And you really did good. Thank you.
It's my pleasure that you are with us today. Thank you.
I think you deliver a very nice meal from lupus nephritis. Yes, the lupus in dialysis, lupus in transplantation. These are another issues that deserve a session, lupus and renal replacement therapy, to be discussed later or in a session for discussion. And I think there are a lot of issues and tips for the management of lupus in end-stage kidney disease patients. Dr. Tariq Tantawi, do you have any points to declare?
السلام عليكم في الأمسية الجميلة ديت، وطبعا بنرحب بالضيف دكتور فيصل واستاذتنا الدكتورة مي والدكتورة علي النهارده.
Very nice presentation.
لأنك أنت اتكلمت بدبس كويس و you got a lot of experiences مع العلم ان سنك لسه صغير، لكن انا شايف ما شاء الله ان احنا ممكن نعتبرك موديل للمانجمنت بتاع حالات اللوبس. الحته فعلا اللي انت كنت مفتقدها
صغير قوي يعني.
بتتكلم معانا على الانتي فوسفوليبيد سندروم، لان احنا بنشوفها ايفن حتى في الدياليسيس، وبنشوف مالتيبل فيلير للفاسكولار اكسس، بالاضافه لو هو في برون ترانسبلانتيشن. ده نقطه ابقى فيري كوشيوس. انت طبعا اجهدتنا بدراسات كتير.
استاذنا دكتور طارق، you remind me by the statement that will consolidate Professor Faisal Shaheen statement about lupus nephritis.
Yes.
Antiphospholipid, this is one sentence. Antiphospholipid is a nightmare of transplantation.
Yes. Yes.
So we should think, and also as well in pregnancy, we should diagnose antiphospholipid before allowing pregnancy. And lupus can flare even after 15 years from remission by pregnancy. This is why we should collaborate with obstetricians for treating ladies.
That's true.
And another point in pregnancy, if we have a case of active lupus and the patient insisted to be pregnant, we should test for anti-Ro and anti-La, because anti-Ro crosses placenta to the baby, and it can cause neonatal lupus, neonatal lupus and neonatal congenital nephritis, congenital heart disease that is irreversible, congenital heart block. To avoid this, one apply treatment. If you have a patient, a lady, was positive anti-Ro, anti-La, and she is pregnant, please shift from prednisolone into dexamethasone, because prednisolone is hydrolyzed by placental hydroxylase, but dexamethasone is resistant to this, and it goes to the baby and prevents neonatal lupus syndrome. I think we should stop here. It is 2 hours now. Thank you very much, all the audience. Thank you very much, appreciating. Dr. Ali, it was very nice, excellent presentation.
Elegant.
Thank you very much. And the presentation in PowerPoint, the video will be uploaded tomorrow morning, and the PowerPoint is already uploaded to the Egyptian Society of Nephrology CME sector, and I'm going to announce in the face to find them very easy. Thank you very much. Hoping you a nice night, and to see you tomorrow, inshallah.
شكرا.
السلام عليكم. ألف سلامة. مع سلامة الله.